Welcome back, everybody. We're continuing our discussion on hypoactive sexual disorders during menopause or low libido. In this particular section, we will talk about the treatment options that are available that you should know about. Start with normal sexual response and function. The World Health Organization defines sexual health as a state of physical, emotional, mental, and social well being in relationship to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. And so the question to ask is, does this problem bother you or bother your partner? And for some people, there is no issues related to the desire for sex. And they're able to enjoy sex in various ways. In others, the level of sexual desire, the response, and the function have become so severely distressing that they need to seek medical care. There are sexual responses in four phases. One is desire or interest, which is what we're talking about today. The other one is arousal or physical changes in anticipation of sex. And finally, there is the experience of the sex act itself, which is the orgasm and the aftermath of that. During menopause, there are other body changes which affect sexuality besides the declining hormones. The loss of muscle tone and pelvic relaxation abilities weakens the supportive tissue of the pelvic floor, and that may lead to uterus or bladder or even bowel wall sagging into the vagina and actually prolapsing out. The vagina or lower abdomen and groin can also have backaches, heaviness, pressure, and a feeling that things are going to fall out. The bladder itself may have difficulty in maintaining its tone, and so there's actually incontinence related to any lifting or coughing or sneezing, which increases the pressure. Urinary tract infections occur at a greater frequency during menopause, and finally, even constipation. Urinary incontinence is due primarily to estrogen loss during menopause. It can cause thinning of the urethral lining and weakening of the pelvic muscles. Although incontinence is common during midlife, it's not an inevitable result of aging, and it should be considered normal or passively accepted unless it's bothersome. Urinary leakage during intercourse is estimated to occur in about a quarter of women who have incontinence, and that will affect the sexual encounter. If you can imagine trying to have sex while you are feeling hot flashes and vasomotor abnormalities of menopause, you can imagine that that is going to affect your sexual desire. Hot flashes actually begin in perimenopause for some women and peak during the first 2 years of the postmenopausal period. After that, they tend to decline, but for some women, they can last up to 10 years or more, and that is more prevalent in women of color. Hot flashes can be negatively associated due to the sweatiness, the uncomfortableness, the disturbance of sleep, to sexual activity. It's hard to be close in bed when your partner is dripping wet. And it has a negative effect on their quality of life as well and is highly stressful. During midlife, women have many stresses. There's no shortage of sources of stress. Our children often reach adolescence and the impact of that. Some of us are adjusting to empty nest or have unexpected return of our grown children. And we come to grips with undesired childlessness that some people have made their choice at the beginning of their reproductive years and now are in a regretting stage. It is during this time that you see higher rates of divorce, widowhood, and marriage difficulties. Sometimes we are the caregivers for the entire family, and worries about aging parents, poor health in our partners. This is also the peak years of work demands. Many women have spent their lives trying to go up the totem pole only to have these stressors occur when their bodies are not responsive. Financial pressures and increasing age-related health worries all contribute to our stress, our fatigue during this time period. These mood changes that occur with menopause also impact our ability to feel sexually alive, if you will. 23% of perimenopause and postmenopausal women have reduced energy, fatigue, depressed mood, frank depression, stress and anxiety, and as a result, poor self image. There is also one of the effects of some of the antidepressant drugs that we receive to try to counter these mood changes may also contribute to an diminishment of sexual desire. The particular SSRIs do that are fluoxetine, sertraline, paroxetine, and citalopram. And so, as a result of the medications we're given, we might have trouble achieving and maintaining arousal and difficulty achieving orgasm. So, there's a need to switch medications that might impact on the actual performance. This midlife time is also a time when some women do not have a partner. And for women over 65, only 7 men for every 10 women because of widowhood or divorce. So that's a problem, even if you have the desire. Also, this is kind of the life of a relationship, and this becomes the time when people have inadequate communication, boredom, or even infidelity. And finally, abuse by a partner or past sexual abuse increases during this period. The other piece of the pie is our partners. 37% of the men, as they reach midlife and older, report difficulty achieving an erection. The problem worsens as they get older, and almost half the men over 75 are unable to achieve an erection or adequate intercourse. So, the flip side, when they get to take Viagra, is that they have erections and are more likely to want to have sex at the same time their partner is having difficulty with their painful vagina and painful intercourse, and as a result, have little or no desire to have sexual activity. Just remember that a normal sex drive is different for every person, and you're the only one who can determine if you have low libido. And so 1/3 of the women who reached menopause no longer felt sexually attractive and lost sexual confidence. But there are a variety of reasons why that happens. It is not just loss of libido. 58% to 80% have actual vaginal discomfort from the vaginal changes that occur with loss of hormones. And so they avoid intimacy and they'll stop intercourse, and less than 7% of them will ever be treated for that. And once they cannot function or don't want to function because of the pain, they lose the ability to function because the vagina becomes stenotic. About a quarter of women have actually hypoactive sexual disorder, that drop in libido. And that's particularly prevalent amongst the perimenopause as well as the early menopause women. It's more common among women who are married or living with a partner because it's more obvious. It is also more common in women who have early or surgical menopause and who have other reasons to have poor health. So, what is it? It is truly a lack of motivation to have sex or even to masturbate. It's a decreased spontaneous desire for sex. It's loss of the desire to even initiate sex and even to respond to sexual stimulation, such as touch or erotic movies. And there are no more sexual fantasies. Most importantly, even though this may occur, it isn't a disorder unless there is distress as a result of it. So if you are have this low libido, but you're not bothered by it, then it's not a disorder. If you have the low libido and the definition that we just mentioned, and you're frustrated and depressed as a result of it, that is the diagnosis. So, what's causing it? I mean, we talked about a drop in hormones. We talked about really the changes that occur in your body with this um, change from robust estrogen and progesterone and to this lower level of all of the hormones that you normally have during your reproductive years. Anything that heightens the brain's inhibitory response will dampen the excitation and put a brake basically on sexual appetite. The major cause of the inhibition of the brain's sexual excitation is really that drop in hormones. But there are other factors, and we talked about them. Psychological factors such as anxiety and stress, cultural, religious norms, and expectations that make you basically feel bad about sexual signals. And finally, the environment you're in, relationship stress with your partner. The most important message I can give you is this is treatable. There is no reason to stay silent or unhappy. 5% of women know it's treatable condition. The medication is one option that you should know about, and you should speak to your physicians and providers about the diagnosis and the availability of the treatments. There are two FDA approved specific treatments, Addy or flibanserin. I don't know if I'm pronouncing it right. It's been around since 2015. It is approved for premenopausal women and also for older women as well. It's a 100 milligram tablet that you take daily, and the pill works on your brain's neurotransmitters to increase desire by taking away the inhibition for it. It does not improve arousal, but it does improve libido. The side effects are dizziness, hypotension, which is its main concern for women older women who might have cardiac disease. It can even cause syncope. And it is contraindicated with any kind of medication or alcohol that can drop your blood pressure even more. But it's been around, it's been tested, and it's available. Its cost depends on truly insurance covered versus not insurance covered, but it is available and you should speak to your provider about it. Velisi or bremelanotide is the newer agent. It is purely for premenopausal use. It's an injection that you give yourself. It's taken as needed about 45 minutes before a sexual encounter, and it's only used one time in 24 hours and up to 8 times in a month. It increases blood pressure, so it's not for patients with cardiovascular disease. And it too, like every medication on earth, has side effects. Most of them are minor, but the main contraindication is women in whom that increase in blood pressure can be problematic. The other thing you can do for yourself is lifestyle changes. Smoking, alcohol reduction, diet. That glass of wine is actually not helpful to improving your libido. It actually mutes it. There are other more sustaining kinds of lifestyle changes, particularly mindfulness and yoga, which improve your body awareness, reduce stress and anxiety, and will enhance the sexual responses. There's a psychological approach called cognitive behavioral therapy. It's very effective for women who have this history of hypoactive sexual desire disorder. It works to change your thoughts and behaviors that inhibit your sexual desire. And it changes your sexual behavior by focusing on pleasure and not avoidance of the sexual activity. CBT can help you change how you think and desire sex. There's also an opportunity to utilize sex therapists. They should be certified in sex therapy, and they help provide additional validation of what you're experiencing. And they can talk to you through the process so that they can help you regain your sexuality and confidence. Other options, including prescription medications, are bupropion or Wellbutrin. It's an antidepressant, but it actually works to improve libido and not just to improve depression. And then hormones. Hormones will be specifically utilized to alleviate any vaginal dryness and painful sex that may make the sexual intercourse more difficult. There are two which have been used and are, if you will, non-estrogen dependent. I can't pronounce it, I'm sorry, prasterone or intrarosa is a hormonal vaginal insert. It's DHEA, which is a protein much like estrogen and actually is broken down by the body into estrogen and testosterone, although not in great amounts. And it's very useful. And there's really relatively no contraindications like there is for the sexual hormones. Ospemifene or osfina is a selective estrogen receptor modulator, meaning that it only hits certain organs that have estrogen receptors. It avoids the breast. It hits mainly at the vaginal tissue, and it's a pill for, so that's easier to take. Postmenopause, we have the vaginal estrogen creams, rings, and tablets. All of these are useful. They're useful because they have only local absorption. So, therefore, they have no contraindications in women who have breast cancer or even breast cancer risk, for cardiovascular diseases and cardiovascular risks. The FDA just recently, last month, lifted the black box warning. So these should be available, and you might have to actually educate your provider that this is now available to you. Even oncologists treating women with breast cancer have used these medications to try and improve the quality of life for their patients. We've talked about testosterone before. It is not approved therapy in this country, but it's important to realize that it is available for use. Very low levels of testosterone can contribute to the reduced libido and weaker orgasms that women suffer in menopause. And studies have shown that testosterone delivered by skin patch actually increases sexual desire, frequency of satisfying sex in women who have menopause and are suffering with distress. The dose is 1/10 the daily dose for men. And it's important to realize that this is not FDA approved, that there's very little research at this point that support it, but it is effective. So why aren't we using it more? Well, for one thing, like everything else, it has side effects. And so women should be aware of the fact that even at this very, very low dose, since it is not part of what they normally have in their bodies, it can have side effects of acne, increased facial and body hair at the higher doses. It can lead to permanent deepening of the voice, weight gain, liver problems, and enlargement of the clitoris, and a drop in the protective cholesterols, which might also translate into higher rates of heart disease, much like men have. Now, this dose of testosterone and use of testosterone has been approved in Europe and has been utilized. And it's primarily used for women who have surgical menopause at younger ages. But it is not FDA approved in the US or Canada. What does that mean? It means there hasn't been enough research. We don't really truly know the doses that are appropriate. And the final thing is there are no formulations to deliver 1/10 of the daily dose for men. And so what people have used is the apparatus that's used to give men their dose, and people measure out 1/10, which is obviously very difficult to do. So be aware of that, and be aware of the fact that with enough advocacy on the part of women, there may ultimately be enough studies that we can go ahead and prescribe this. But for now, it isn't a usual treatment, and the other treatments are more appropriate since they have been well studied, are used, and are available. Testosterone in pellet form should be avoided at this point because we don't even know how they're made. And some of these spas that provide that, or over the internet dosing, you have to be very careful about. The other thing you should be aware of is that Viagra is not for women. It was never formulated for women, and so therefore you think that you could use it to get the same erection as men do, but that's not appropriate. It can increase general blood flow, but it doesn't increase desire or arousal compared with placebo. And so don't go out and buy those $1 Viagra tablets thinking that you can use them like your husband or your partner does. There are other options as well, and I think it's important that you consider them. The use of vibrators will help women with arousal and orgasm problems. They do increase genital blood flow. The clitoral therapy device called AeroCTD is approved by the FDA to treat female sexual dysfunction. It's an actual suction that draws blood into the clitoris so that it swells and it can cause or contribute to an orgasm. It requires a prescription. It's expensive and it's usually not covered by insurance. And finally, for those that have had the sexual stenosis, there are vaginal dilators that can be used to increase and stretch the vaginal muscles. Want to reiterate that painful intercourse, pelvic muscle dysfunction can be treated with various other therapies, specifically pelvic rehab. The Kegels that you have all heard of actually strengthen the muscle floor and help to improve sexual function. So we've gone over all of this, and I want you to realize that you should not despair, that this is available. You should also not be silent. And to bring this up to your provider is really relatively simple. And that is to say, you've had some issues and concerns about your sexual function and intimacy, and you would appreciate some help. And as I said, there are treatments depending on what the cause of the problem is. And so women should not be silent anymore. Thank you.